Hello, everyone. It's another Live with CCO. We're on episode 81. And as always, we're going to have fun today because we're going to talk about the CPT updates. We're ready for 2023. There is always, every year, new, changed, and deleted codes. For the most part, we're not going to talk for a long time about the deleted codes because the deleted codes are usually a direct result of the new codes. However, we will kind of peruse over them. And I think this format that we did for our ICD 10 updates for 2023 worked so well. We're going to do it again. I know that everybody's interested in the changes. They want a heads up to see if a particular area got a heavy hit in the changes, and we will see some of those. Uh, it but it gets to be kind of a droning process to go over the changes. So it's our goal to always have fun as we educate you. And I hope that in turn you appreciate that. You let other people know that we're offering these CPT updates and that you enjoy the format that we use. Let's go ahead and get started. I've got my eye over here on the chat in case there is any questions that you have as we go along. The first thing we want to cover is what were the totals for the changes. Now, does it really make that much of a difference how many or codes were new and revised and deleted? Sometimes it does, but of course, every year the number one number or total will be the new codes. And then again, you can go back and look at our previous updates that we've done, and you'll see the same kind of format. We have a lot of new codes, we have some revised codes, and we have a few deleted codes in the scheme of how many codes there actually are in total, right? So this year for 2023, we're going to see 224 new codes. We're also going to see 96 revised codes and 75 deleted codes. One more thing just to reiterate that the deleted codes are almost always a direct result of new codes that were added, and therefore we won't spend a lot of time on those deleted codes. If there is a specialty that you're involved with, and as we're going through some of these, you want me to slow down or talk about those in a little more depth, feel free to mention it in the chat, and I'll keep, again, that eye on the corner screen there to kind of break that out for you. All right. As we start, let's do a quick review for any of you that are new to the CPT code set. CPT and HCPCS, actually CPT codes are HCPCS codes. You may not have known that, but they fall under that same title, but they have two separate manuals. So most people don't realize that they kind of are the same code set. But the CPT codes are divided up into categories. We have categories 1, 2, and 3. Honestly, I don't think of them as categories. My brain is just a tad bit wonky when it goes to thinking about the code set. I think of the code set as a translation or a special little secret code that we use to translate the documentation. You know, I'm always saying, and someday I hope to see this in print, my little motto that we code for statistical purposes. It happens to be a convenient way to get paid. And those statistics are based on the disease process as well as what we do to the patient to be able to maintain their health or improve their health. But the CPT codes are all about what we do to and for the patient, the procedures that are involved. And the category 1 will be always used for tracking and billing, which tracking, they mean statistics. Category 3, they're optional codes. Category 2, did I say 3? Optional and intended for measuring performances, quality Hedrix, HEDIS, things like that. You'll see those two. And then category three, they're temporary for emerging technologies. Now, if again you're getting ready to test or the code set's new for you, absolutely the category one codes, that's the bulk of everything you see in that manual. That's what you'll be tested on. They will talk about these others. You may get an emerging technology code from time to time. However, you do want to know that category two codes are um, performance measures, and there is absolutely a purpose for them. I think we've done some education in those in the past. You may have to jump out to our YouTube channel and see more about those if you're interested. Well, again, we have some great tools and options for you. Let's get this out of the way. I don't want to forget to mention it, but if you are needing an encoder, we really like Find a Code. I know that you see that being used in our webinars a lot. We're going to rely heavily on that tonight because, again, one of the reasons I like them is they are, in my opinion, educational based. And so instead of pumping all this information out via the slides, the individual slides, and kind of doing it the boring way that everybody does, we're actually going to bring in the encoder and show you how we find these new codes. I am positive that all encoders do this service for their clients. So I would encourage you to look at the encoder that you use that lists the new and updated, deleted, revised, all the codes for the code sets, not just CPT. There has to have an area or a list. But again, I really like the way that Find a Code does it. If you are interested in in getting an encoder, please check them out. They are aligned with us in education, and they will offer you a discount if you let them know that we sent you. That's cco.us/find a code. Again, this is some perks. They work with us in showing our BAT technique, the bubble highlight and annotation technique that Laureen started back in '99. And we've been incorporating that to show you how to do it in Find a Code. Really cool, I know. So I like to always start with the E&M codes. We get those out of the way. Not a big change this time, and that is probably a direct result of the fact that last year we had major changes. Again, if you need some more information about those changes or education on those changes, you can reach out to us, but we have done a lot of YouTube webinars that you can go look at for more information. The new code is that they added is prolonged inpatient observation. You knew this was coming. They had told you it was coming, but they hadn't finalized the wording on it. Now it's done. So 99418 is going to be prolonged inpatient and observation, and it is an add-on code. I suspect that many of you are already familiar with this code because we did get a heads up about it. We knew it was coming, and I think we also did education just on this code recently. So we won't talk about it a whole lot. Just know that 99418 is an add-on code for prolonged inpatient or observation services, and that add-on codes are not used as primary code. So it can't be used by itself, right? So it's got a parent code under it. Then, even though this is not an E&M, there was another couple codes that were new. And then when I was going through the changes, I couldn't find where to put these as far as what category. And honestly, it was a little confusing to me. Behavioral health, I've worked in that before, but not these codes to me seemed completely new out of the blue. I wouldn't mind you giving me more information about it if you know more about these codes. 96202 and 96203 don't fit in. It's like they're completely new, that they didn't fit in the code range that I thought that they would. I'll show you that when we are looking at the code ranges in a little bit. So Again, just making you aware that multifamily group behavioral health has two new codes, and the 96203 is an add-on code. I didn't put the little plus symbol in there yet, but anytime you see each additional 15 minutes, then you know most likely it's an add-on code. And the that means the parent code would be 96202. This is multifamily group behavioral management modification training, and then it goes into that all that information that they put in that's kind of standard about who can do it, qualified professionals, et cetera, et cetera. Again, really interested to see if you know more about these two codes. I did a little bit of research, but mostly they just said, hey, these are the new codes. uh, so we might have a topic in the future regarding these if you are interested, but not in my wheelhouse. I was a little surprised to see those that they didn't fit into the code range. So I guess the code range will change to expand out and fit these two new codes in. All right, then we get to the bulk of what we're going to talk about tonight. Most codes are in the surgery section. Again, if you're new, you may not have been aware of that, but the CPT codes, the largest amount of codes in the code range is going to be the surgery section. So let's look at them. These are the code ranges for surgery. I like this because it kind of gives us a better idea of what areas are covered within the CPT code set. And what I decided to do was just highlight the ranges that had changes, had new codes added to it. Now, I'm not talking about the revised and the deleted codes, and we do know the deleted codes are probably a direct result of the new codes. However, not every range had new codes added. And this gives us kind of a bird's eye view of what the focus was for new codes this year. So we know the integumentary system, musculoskeletal, respiratory, and cardiovascular. Again, that's pretty common. Those usually get heavy hitting changes both in CPT and ICD. Then we jump to the digestive system. There was actually only one code added to the male genital system, and only three codes for procedures of the auditory system. I went ahead and put that off to the side for a reminder to also make you aware that when there are changes, sometimes you'll get a lot of changes. You may get 20 codes in one area, or you may get just one or two. And ultimately, they equal up to that over 200 codes that we have that are new this year. So this again kind of gives you that bird's eye view of, hey, what didn't get new codes. And I hope that's helpful to you, because if there is a specialty that you deal with, you're able to just look at this slide and say, oh yeah, well, let's see, I do OB coding, not going to be anything there for me, or I work in the endocrine system. Yeah, nothing for me. If you work in cardiology, absolutely, you had a lot of new codes there. So here we have kind of an overview of the changes. So what are we going to do? We're going to go look at those changes real quick. And the way we're going to do that, I'm going to go ahead and pull in find a code. Now I already have this brought up. We'll be going back and forth with this as we're working. When you go in to find a code, you're able to pick which code set you want to look at, and we picked CPT. And right here on the information section, I'm able to see the new codes for 2023, changed and deleted codes, reactivated codes. There's none in the list, but again, that's always mentioned every year. Sometimes, maybe someday there'll be one in there. I don't think I've ever seen one in there, but it is actually possible to have a code reactivated. And then notice they still have the 2022 changes and updates available there. I think if you check, I think you can also access, if you go into the CPT code information, all the way back, so that you can track all of the new codes that came out in the previous years. Now, if you open up a code within find a code, it'll tell you up in the upper right hand quadrant there of the screen when the code was implemented. And so you don't necessarily need to look at a list like that unless it has something to do with changes or something pertinent to what you do. I suspect it could be helpful. So we're going to go ahead and just open up the new codes. And I love what they did here. First of all, you may have wondered, how did I know there were 224 new codes? Well, because they told me. I didn't go out and count every single one of those codes. That's just not very bright, right? It works smarter, not harder. Also, you'll notice that in this list it runs alphanumeric, which is very helpful. Well, CPT codes actually don't have a character in the front that is an alphabetic number, so they go numerical. But um, we're not going to spend a lot of time on these codes here because those are category 2 and 3 codes. We have again done some education in the past, and it may not be on YouTube per se, but I know that in our educational wing of CCO for our students, we talk about these codes much more in depth. So we're going to kind of skip through these because, again, you'll see even with the first one, it's about vaccinations. And it starts out, so they have gotten new administration of COVID codes. Uh, you see the SARS uh, code. So why did they do that? So they can track how many people are getting those additional doses. Notice here it is third dose. Here's booster dose. Again, third dose and stuff. There wasn't ever per se a reason to do that in the past, and now that people are getting additional uh, vaccinations and boosters and stuff, we want to statistically track that, how many people are getting them and how does that affect their health. So we're able to do that with these CPT codes. That is the purpose of them. And we're just going to skip through these. Again, these are not ones that are, unless it's something particular to your field, these aren't probably mainstream codes. So we can talk about those at another time. Let's get to the meaty stuff. Let's get to the surgery codes and look how many of these codes were changed. All right, here we go. The very first code, implantation of absorbable mesh and other prosthesis. Oh, real quick though, let me just set that there. Let's go here. Oh, nope, not radiology. Nope, 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 not yet. I thought I had a slide for that. Sorry, hiccup. 15778 is implantation of absorbable mesh or other prosthesis for delayed closure and defects of the external genitalia and, let's see, perineum and abdominal wall due to soft tissue infection or trauma. Now, that is was a needed code because they had to use whenever there were complications, then this was a result. Now they can track that. But that code wasn't as impressive as these two next codes that I thought were going to be very, very helpful. Look at 15853 and 4. Removal of sutures or staples not requiring anesthesia. And you list it next to the E&M code. What happens is the patient had stitches or staples and they come in and the nurse pulls those out, right? Uh, we used to have one code for that. Now we have two, and uh, very, very helpful to better explain why the patient was coming in and seeing the nurse, not seeing the patient. We can track that. Now, notice here that 15853, removal of sutures or staples not requiring anesthesia. And if you look at the two codes, do you see the difference in those two codes? Mm-hmm. Okay, let's just open them up real quick. And remember, I told you it lets you know when this new code was added. This is also helpful in that they're telling you that this code will not be added to your lookup until January 1st, 2023. Uh, what Find a Code does is they put it in kind of a separate category so you can look at it in the new area. But again, this is a preview. They technically AMA could change something. I think it will let me jump to the next code. Nope, no, it didn't. All right, never mind. I thought it might. Okay, so ultimately we have two codes for the addition for removal of staples. Now let's move on. Here we are into the 2000 codes. What are those? Well, remember, we can go back and look, and I need to go back one slide. Here we go. We did integumentary system, just two codes, but we have the musculoskeletal system that is 20100 through 2999. And here is the new updated code: total disc arthroplasty, or an artificial disc. If you do surgeries for the spine, here you go. It's the anterior approach. They always tell you what the approach is in these code, and including discectomy to prepare interspace, meaning they got to pull out the other code or the vertebra and put this one in, and so that's kind of fascinating. Moving on immediately to the 3000 codes. And what are we looking there? Look, I can do this. Isn't this nice? Respiratory system. And you notice it said nasal passage because it is part of the respiratory system, our nose. Just like teeth is part of the digestive system. So we're going to repair nasal valve collapse, and then we're going to be able to do percutaneous pulmonary artery revascularization, which moves into the cardiovascular system. Notice they're all starting with a 3 all the way down to the mediastinum diaphragm. Why do you think respiratory cardiology, the lymph nodes, and the mediastinum and diaphragm are all starting with a 3? Now I know that's 30,000, but I call them 3,000 codes. Just excuse me for do that. I know there's 30, it's 30,000, but it's just easier to say those codes that start with a 3. I say the 3,000 codes. It's all because they're in the same body area. I feel this is going to be the abdomen for the most part. Now, of course, we have the respiratory system, the neck and above. However, isn't that interesting that those are all predominantly in the same area? And then we go into the fours, which is digestive, urinary, and we just keep, as the numbers get bigger, we're going down, 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 down the body system. I think that's pretty fascinating. All right, so let's look at those. Now we jump into cardiovascular. We're going to be able to do percutaneous pulmonary artery revascularizations. If you're a circ coder, then these are going to be pertinent to you. Yep, Johnny said cardiothoracic area, absolutely. And if you are new, and what might be beneficial to you as you're learning more about the code set, Johnny brings up a great point. If it's the cardiothoracic area, and you kind of lump these codes together when you're abstracting for exams, it's going to let you eyeball those multiple choice faster. Right? So if you see a code that starts with a 1 or a 2, and it's something involving the, as Johnny said, cardiothoracic area, heads up, not probably going to be the correct code in the area that you're looking for. There were several of the new codes. Notice they all are in a range: percutaneous pulmonary artery revascularization, and we have unilateral, bilateral. We've got normal native connections. Let's see, pulmonary artery. What's the difference by stent? Initial, normal, abnormal connections, and then we move here to the same thing. Let's see. Yes, each additional vessel or separate lesion. Again, if you're a cert coder, this makes perfect sense to you. Then we're moving on to percutaneous atrial venous fistula creations. So what are they doing? They're putting in stents. Maybe this person is having um, they're going to be having dialysis possibly. I think that may be what those codes are for. And we jumped from the 3.3s to the 3.6. We're still cardiovascular. And then we jump into the 4 codes. Now we get into right here. Look here. See what I said? Digestive system. Now, after the digestive system, we're still going down on the body, but we're gonna skip urinary. Had no changes this year, and only one in the male genitourinary. Let's see if we can find that. So, esophagogastroduodenoscopy. It's not duodenoscopy. Flexible deployment of intragastric bariatric balloon. What? What? That is for people who are having gastric surgery for losing weight. That's what that is. Ah, isn't it interesting that as they've been progressing and doing more of these procedures, there needed to be a specific code for that, and technology and the ability to create new devices as a direct result in the changes in our code set. I think that's fascinating. And if you've never seen that, what they do is they literally go in through the throat down the esophagus, and they deploy this balloon, and that balloon is blowed up, and then food that you eat will go around the balloon, but the stomach's already filled up, so you have a full sensation. And then when they're ready to get rid of it, they just go in and deflate that balloon, and they pull it out. Pretty cool. Now, let's see, and these are all transoral, so that means that it is minimally invasive. Mhm. Now let's jump down to 49591. We're going to look at the abdominal hernias. They're doing repairs, and it says it can be done epigastric, excisional, ventral, umbilical, or uh, spinguline. I'll have to look up the phonetic pronunciation of that one. Wasn't prepared for that. And they can do open laparoscopic or robotic, but looks here. Oh, always remember these codes are based on diameter and size. So we have a 3 centimeter reducible. Then we have incarcerated or strangulated here. Here we're moving up in size, still reducible 3 to 10, and then incarcerated or strangulated. You'll see that's why there's so many codes in this area, because every single one of the codes will have those options based on size of the hernia, and is it reducible, meaning can they push it back in, or is it in incarcerated or strangulated. You definitely don't want strangulated. And then greater than 10, again, we got to have those. And then we're doing a different area. Those were anterior abdominal. These are anterior abdominal hernia. You got to look for the little, any approach. Recurrent. These are recurrent. That's another thing that you look for when you're dealing with hernias. And not notoriously, what would be the right word that I'm looking for? Not notoriously, but historically, that you'll get a hernia, some type of hernia uh, question, hernia repair on the coding exams. And one of the reasons I believe that is because you have to pay attention to the details, just like I mentioned. Size is, do you know what the difference is in being reducible, incarcerated, or strangulated, and recurrent or not? These are all details, and that's what they're testing you on. Anybody can look up a code, but these details are permanent, are pertinent in getting to the highest specificity. Let's see. Sarah Perry says, "Is this what the bat technique helps you with?" Absolutely. You nailed it. Sarah, thank you for mentioning that. This is exactly what helps you with the bat technique that Laureen came up with in the back in '99 to be able to get to the highest specificity and narrow down the focus as you abstract the codes from the documentation, being able to look at your coding manual and have everything after. And here is a perfect example. So the way that is done is this would be highlighted less than 3 centimeters reducible, and then anything that needs to be underlined that's permanent, like this word here, recurrent. And so when you look at your coding manual, you would say, okay, well, this is a recurrent. Oh, okay, here's the bubble and highlighted area for repair of anterior abdominal hernias. That would be bubbled. Then what's the key word is that it's less than 3 centimeters and it's reducible. That's highlighted, everything after the semicolon. And then what's going to make these codes different from each other? Oh, this one's recurrent. So that's perfect. Thank you for mentioning that, Sarah. It really not only saves you time when you're testing because you got narrow focus and you don't get distracted, but in addition, it helps you get to the highest specificity and remember what's the difference in the codes, right? Especially when you're relatively new to coding, you may not be dealing with this type of codes in your everyday work, or have dealt with repairs of hernias or any other specific area, and it narrow focuses on what's the difference in the codes, because otherwise you're just looking at a paragraph of blah blah blah, especially when you're nervous and taking a test. All right, let's jump down. So all of these are repairs, and those now we have to do all the same ones for recurrent. Now we have different, here we have a different area of hernia, and notice size isn't pertinent with this type, but reducible, incarcerated, strangulated, and here's an add-on code. Now, how do I know that? Because it says list separately in addition to, so it's probably an add-on code. Don't code those add-on codes as primary. Now, let's move all the way up to 55867. That is our one male genital urinary code, I believe. Laparoscopic surgery, surgical prostectomy, simple. Subtotal includes robotic assistance when performed. So let's see, including control of postoperative bleeding, vasectomy, mediotomy, urethral calibration, and or dilation, and internal urethrotomy. So fabulous. One code added to the code set for that procedure that's probably really, really common. Then we're going to jump all of the way down to surgical procedures of the auditory system. There's only 3 in there, but look how quickly we're able to navigate this. And as we're doing this, I hope this is more interesting to you than listing every single code on a slide deck and trying to fit them all in. Gives us a chance to kind of discuss them a little bit more and break them out. The purpose of the codes. We go to 69726, and again, this is auditory system. So what are we going to do to the ears? We are going to do removal, entire OCO integrated implant, skull with magnetic transcutaneous attachment, cochlear implant. They're removing it. Ooh, okay, so that's pertinent, but notice on these codes we go through everything that's after that would all be highlighted. So we're removing an implant, and the pertinent information is that outside the mastoid and involving a bony defect greater than or equal to. So we have size here, and that means that we also have size. This one is implantation of the cochlear implant. Let's see, same size. Then we go to replacement, including removal of assisting device. That's going to be pertinent, right? This is not something I deal with, but my niece does have um, a cochlear implant that she got a few years ago. She's in her mid 20s, and she waited until I think she was 22 to get her cochlear implant. Being deaf for many years, she was nervous about getting it done. Has been a game changer for her. So if they have to replace it, uh, one of the things they will sometimes you have to code for the removal and then you have to code for the replacement. So now we have some changes in removal, implantation, and replacement of the device. Very good. Now we jump down to 76883. This is not in our surgery section. Ultrasounds, you notice that said ultrasound, not in surgery. It's actually in radiology. Ta-da! I just recently did a lecture for a college in New York that they taught sonography. So they were all getting ready to graduate and they wanted to know more about the code set. That was a lot of fun. We'll have to present that for you guys sometime in the future. I also saw in an article that was pretty fascinating that the least stressful job in the medical field was diagnostic ultrasound. And I told that to someone I know that does ultrasound work. They said, well, where'd they get that idea? Hmm. All right. So, radiology, let's look here. We only had one code. Here are our code ranges. Good to know, but only one code. Let's look at that code now. That is for an ultrasound, nerves and accompanying structures throughout the entire anatomic course in one extremity, comprehensive, including real-time imaging and documentation per extremity. So if that's the case, that tells me that if you have to do more than one extremity, you must have to use this code more than once. Times two extremities, four extremities. We have to four extremities. So, interesting. Then we are going to move to 81418. This, another completely different area. Let's see what we've got here. Path and lab. Note, you guys, if you know anybody that's getting ready to test, or if you're testing or taking your education, I hope you're taking your education with us. But if you're getting ready to test, medicine and path and lab are the two areas that most people struggle with the most. Historically, when they tell us, especially well, we get a lot of people that will take the test, not pass, and then realize, hey, we need some supplemental education. So they'll either get the bat technique blitz videos that we've created, or they'll start the course that we offer. But path in lab, when they let me know the areas that they struggle, especially if they've tested once, path and lab and medicine, number one areas. So we had changes in two areas. Now, notice how extensive path and lab is. So I scrunched everything down that wasn't pertinent and highlighted. We've got chemistry procedures and microbiology procedures. Um, let's see. Oh, Sarah says the worst section ever. Uriel, I don't know. You said, wait, what was the difference? I'm not sure if that was the code. Go back and check on the code. Sorry, I can go back and look. Let's get through Path and Lab and let me know which one that you're referencing. I'm sorry, my eyeball didn't catch that in time. So we did the ultrasound. Maybe that's what you were asking about. Ultrasound per extremity. And moving into drug metabolisms, and it looks like it's specific type of analysis, duplication deletion analysis of these. And honestly, unless you deal with this, not going to make any sense to you. However, all you have to do, guys, little tip, is take this little piece right there, Google it. It'll pop up, give you all kinds of medical information, and increase your knowledge on what this is, specific genes that they're looking for. I do that a lot when I'm doing research or doing audits and I see something I'm not very familiar with. Moving right on, we have inherited bone marrow failure. Interesting. And this is why it really confuses people because all of this is scary to look at it's not something we deal with. But I want to bring something to your attention. Inherited bone marrow failure syndromes. But when you look on here, is there anything that leaps out at you that um, um, you may not have been or that you recognize? It says it must include sequencing of at least 30 genes, including this one right here, BRCA2. You know what that is? Anybody? Breast cancer, right? BRCA2. So this is looking for inherited bone marrow failure syndromes, but it's going to be looking at all of this stuff. That's, again, one of the reasons why Path and Lab is confusing. There's rules. We don't have time to get into the rules. We have done a lot of education in this area, and if it's an area you struggle, tell us specifically what we can assist you with, and we will create education to help you. Then we're going to just go through these pretty quickly, just kind of give you a brief heads up. Targeted genomic sequencing analysis panel for solid organ neoplasms. Very interesting. Let's see, still got those targeted genomes. I'm wondering, and if some of you guys work in this area, I'm wondering if the reason these are new codes is some of some of these things that they know about, they can test for now. And they added them. Could be. That's why there's new. Again, let's see. I'm not seeing anything that jumps out that I'm familiar with off the top of my head. If this is something that really rocks your boat, though, you can go in and look these up. I did look at them a little bit, but notice this one: infectious agent genotype analysis and acute respiratory coronavirus. There you go. Mutation identification in targeted region. Interesting, isn't it? Some vaccine information. This is getting us into another area. So what do we got now? Microbiology. So we did chemistry and we got all the way through to microbiology now. Those code ranges. We're ready to do 90584, which is the medicine section. Yep, that's right, Sarah. You're right. Breast cancer, you got that. If people who test for BRCA2 are their possibility of getting breast cancer is elevated exponentially. I know that when my mother had breast cancer, and several women in our family, in her family and my father's, had had breast cancer, so my sister and I got tested, and no, we didn't get tested. She got tested, and she was not BRCA positive. However, her cancer was HER2 positive. So there was a few things, and we're on the watch list. So we go in every year and have ourselves tested because our risk is higher. And isn't it brilliant that they can go in and test that? Now, this helps me. I have 2 daughters out of our 6 children, and therefore they are now hypersensitive and aware that it's something that they will check for in the future. There's a lot of women that if they're BRCA positive, they will go ahead and choose to prophylactically have bilateral mastectomies and reconstruction done so that because it's that high of evidence based on the statistics of what we do. We give them that information. It's so cool. All right, now we're going into medicine. 90584. Dengue vaccine. Dengue. That is a name. I've seen it in movies. Dengue. I can't pronounce it though. I know it's on the tip of my tongue. I've heard it in movies. It's like something something fever. Um, and so again, they've added that. Then we have respiratory. uh, I could be getting my glasses on, and that could probably help me. Actually, I have my pink glasses, but my everyday glasses, but I think I'll put on my really cool readers. Whoa, look at that. All right, because then I can do this and look super smart for you guys. My intelligence dengue fever. I don't know if that's how you say it. It says Matamaster. Uh, dengue fever. Is that how you say it? I don't know. Phonetically put it in there for me because now that's gonna. I'll go look it up after we get done. Um, let's see. Respiratory. We've got a vaccine there. Dengue. Okay, Sarah got it for me. Phonetic dengue fever because we've heard that in movies, right? I think it's something you get when you go into the Amazon or something. Let's see. Then we jump down for more tracking of SARS. Um, and let's see. Of course, we knew we'd get a lot of these. Look how many we've got. 1, 2, 3, 4, 5, 6, 7. 7 codes added for the medicine section. And notice the difference in these, the dose. All right, so there's a little bit of differences. That means in the medicine section, and I, I don't know if they will test heavily in this because this stuff changes so much. It really wouldn't be cost effective for them to be putting a lot of test questions for SARS and things, although I could see it happening. But it's all about the details here, you guys. So now we're going to move on down to orthopedic training under supervision. What? That's because we have moved out of the medicine section. Nine five seven. No, 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 no. 9-2. Yeah, no, no, I'm wrong. Okay, so we did our vaccines and toxins, and then we go into gastroenterology procedures, which is this. There was only one. This one right here. No, no. I thought there was one, but that is 91309. Yeah, see? Very interesting. I may have made a boo-boo on the highlight there. That says orthopedic training during supervision or physician or qualified healthcare profession. That that doesn't meet that's something odd. Okay, well we can look into that further. Let's jump down to 93569 all the way here. Cardiovascular procedures during cardiac catheterization, including imaging, supervision, interpretation, and report for selective pulmonary artery angiopathy, unilateral. Now, key, unilateral, bilateral. Got it, right? See the difference? And then these are still of each distinct pulmonary vein. That was part of it. During cardiac catheterization, list separately. That's probably an add-on code. And then we move on to branches. And then we jump down to quantitative measures, which is going to get us into 959. Right there. Neurological and neuromuscular procedures. Let's see what we got there. Very good. All right. And then multiple family. These are those 2 codes right here that I told you about that threw me, that I wasn't familiar with. And when I was looking in the code ranges, like it didn't fit. There is no 962 area. And I thought, well, then they may have just, but that is right there in behavioral. So I think they may have their own little area. If that is true, that's kind of exciting because that tells me that what they're going to do is there is going to be more codes added to that because we're expanding behavioral health. Vicky says any major changes in E&M? Absolutely not. No, no. Right at the very beginning, we talked about that new add-on prolonged service for initial observation. We kind of knew that was coming, but they didn't make it official. Uh, and that's the only change in E&M, right, Vicky? We should do a little golf clap. Hooray! Yeah, everything was done last year, all those major changes. Now, will there be changes next year? Possibly, as they fine tune and tweak, but I think everything's going pretty good. I am so thrilled about the E&M changes because it just makes sense medical decision making to me. Moving on to remote therapeutic, and that's this code right here, Vicky. Just so you know how apropos that you would mention it right now. The 99418, this add-on code. Notice the little plus symbol there, is the add-on code for prolonged services. But then we are going down here to 98973, which is the this is non-face-to-face, non-physician services. And then that was it. That was the last one. Let's just look at it real quick. Man, I can't believe how fast we went through those. There it is, 98978, remote therapeutic monitoring, therapy adherence, each 30 days. Okay, now real quick, we're not done. We're through the home stretch. That's the bulk of all the codes, and want to remind you that if you want to be part of our club, it's a great dynamic area to find out about changes like this. We have webinars and support that's all private for our club members. They always take priority with everything that we do. We get some excellent and amazing discussions and questions in there. Was just looking today at an op report where somebody had said that these were the codes they thought, but there was one code that they were struggling with, and was able to jump out and do some discussion and research on that together. It was a lot of fun. You could be a part of that. And we have a lot of product support that's also in there. Oh, sorry, let me get rid of this. The CCO Club is just fun. We enjoy it. Plus, CCO Club members have access to CEUs. Want more information? It's really easy to find, cco.us/club. Now, let's talk about the deleted codes. Deleted codes, woohoo, very easy to look at. I already have those up. There were only 75 codes, and look, these are all in that area that this is all stuff that's being tracked. Remember, I told you those two in category 2 and 3. What happens when they're deleted is that they are either changed. Deleted codes are usually a direct result of those new codes. So here's the first one: removal of sutures under anesthesia, same surgeon, 15850, out. And now because how do they usually do them? They just come in, the nurse pops them out, right? So now we can use those other codes. And then here's all of those hernia repair codes. They were deleted and expanded. Notice how short the description here is and how long the description is in the new codes. That's why. So then we get into, those were all those hernia codes. Still hernia, woohoo, repairs of hernia, so many. Now, then all of that was 99217. This is observation discharge day management. They deleted 99217 and 218 for initial observation care. Then all of those were deleted. Subsequent observation, still moving down. Office consultations. You know what? It's nobody pays for consultations anymore. I'm not surprised that they finally went ahead and got rid of them. Everybody uses E&M codes instead. Nobody pays. Evaluation and management, we went into 99318, and again, you asked about any major changes. Nope, they just got rid of some of the codes that we knew that were going away. 99324 for home visits, And all this stuff was deleted, and we had some revisions that we'll see in just a moment. Those will pop up there. Um, let's see, prolonged services. Again, these are the deleted codes that we knew that were coming that are now covered in the prolonged services area. I'm going to get rid of this, and I'm going to first, before we get into the changed codes, talk about our YouTube channel. You guys make our YouTube channel so fabulous. We put the content in there and we hope that you enjoy it. Please let others know. We don't really advertise, but I know that if I watch YouTube videos, they always say, hey, like and subscribe and hit the little bell, ding, 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 and whatever they have to do to make you do that. It does help us if you subscribe and if you share our videos. And this in turn tells us where to focus our education. Our goal is to assist you in any way that we can. And we have almost 50,000 subscribers. In the scheme of things of social media, that's really not very many. I think it's 100,000 that is the big deal. But I think the fact that we have so many views is more important, and that's all because of you. So, if what we do is helpful, subscribe and do the little bell thing or whatever you have to do to know when we're going to do another video. Notoriously, we do. Not notoriously, historically, we do Tuesdays and Thursdays. We like to do live webinars for you guys. Sarah says, what is the difference for suture removal new codes versus the 99024 with Z4802 encounter for suture removal? That is, as far as I know, Sarah, that it replaced that, and we can tell you because I can put in the, I think it's because it goes on the EM. So this one here is that she's asking about is post-operative follow-up visit. And I think it has to do with surgery versus somebody going in and just having sutures taken out. This is a global package, part of, it has to do with packages. See, it says as a component of a surgical package, see surgical guidelines. And then it further explains here that normally includes part of the surgical codes, but you have to say why the person was there. Doesn't mean that you're going to get more money for it, but you do have to track it. But this is something like where a person, cuts their finger and gets stitches, and then the new code, they can come in and just get those stitches removed. That's, I believe, the purpose of those. Just wrapping up on the YouTube, it's real easy to find it. It's youtube.com/CCO. Super, super easy. Let's talk. We talked about the change codes. Let's talk about those change codes now. We talked about deleted codes. Here is the changed codes. Now, with changed codes means that they changed the verbiage or the wording a little bit. So let's jump through all of these category 2 and 3 codes and look here. Removal of sutures or staples requiring anesthesia. Look what they did. They changed the verbiage a little bit. Then they jumped down to that arthroplasty. They not only made a new code, but they changed the verbiage. And here it says this was added code. And then here, notice when we jump down, again, added, but code description changed. So revision of the bypass graft, if you guys are doing that cardiovascular and you've got the CERT credential, then um, actually that's revision of that bypass graft in the groin. That wouldn't probably be CERC. Percutaneous nephrolithotomy. Ooh, there we go. Kidneys, and code description changed with all of these codes. Injections for anesthetic. And when you go in and you look at the previous, let's take 64416. I can show you just real quick as we wrap up. what it looks like before and after. So, injection, anesthetic, and or steroid, plexus, right? But this says brachial plexus, continuous infusion catheter. And then this is this is what it said before. So what they added is including imaging guidance when performed. That was what was added. Look, that was added here too. So that verbiage included that on all of those. Interesting, right? That's all they did was add that. Transluminal dilation of the aqueous outflow canal, canioplasty. I'm just real quick curious now. What did they expand that? Because I find a code is so cool. Dilation aqueous canal flow without retention device or stent. Oh, they added uh, canioplasty. That's what this is. All right, so it looks like again, ultrasounds got some touches here, and that's good. Oh, and here, usually they just put more information. I don't see anything that jumps out at me with these. I didn't when I looked at it before. Just take a look again. Oh, E&M initial hospital inpatient encounter. Let's see. I think that verbiage is clear too. 99221. Just real quick. Actually, I think they decreased the verbiage on this one when using total time. They did. They decreased the verbiage of that one. Look. So that's kind of cool. Fine tune it, made it a little, oh, 40 minutes must be met or exceeded. And this one says typically 30 minutes are spent at the bedside. And that verbiage has changed quite a bit. Interesting. I may have to go back and do a little more information about those changes of the verbiage to clarify. But again, when that happens, it usually is for the better. And so it's self explanatory. All right, guys, I think we're about ready to wrap up. The changes were so easy to go through. The CPT changes for 2023, not a lot of really drastic changes, a lot of things we were already expecting. A couple, hey, wow, that's really cool, right? Those, but for the most part, nothing like last year where we had extensive E&M changes that got a lot of the focus. I think this was a pretty light year, 2023, for changes, which I'm grateful because of 2022 being so heavy in CPT. And real interested in your thoughts about the changes. If anything leapt off the page when you notice changes that you would want us to discuss more, or that you're pleased with the change because it better explains a particular code that you're working in. I always like to get your insights. Let us know what specialty you deal with, if you're in a specialty, or how any of these code changes affect you in 2023. In the meantime, we appreciate you joining us. We have so much fun doing these for you, and we need to know what you want us to expand your knowledge on. I know that Jesus posted earlier that we have a topic request link, and he'll post that again, and let us know. We want to meet your needs, And in the meantime, reach out to us on our social media. Now that you know that we're not only easy to find on YouTube, that you're going to like, subscribe, hit that little dingy bell thing, and tell everybody about, but we're also on LinkedIn and Facebook. So easy to find. And you can always send us a note. Just go to our website, cco.us. In the meantime, the best way to stay connected with us, and always takes priority, talking with all of the CCO staff, is at the CCO Club. And that is cco.us/club. Minimal cost for the value, in my opinion. Of course, I'm biased, and might be a good Christmas gift for yourself in the new year. Tell your friends, and we hope to see you in there soon, where you can get some great CEUs. All right. Thanks, guys. Have a great rest of your year.
Do you need more medical certification and business training? Learn more at www.cco.us.